Thank you, Lonnie, and for those who have the ability to do this, I work every week. I see 5 to 7 new lung cancers on Tuesday, and we do a combined thoracic oncology tumor board on Wednesday where all the new cases are presented and the difficult return patients. So I love the idea of this multidisciplinary approach, and if you don't take anything out of today, you should really take out that there's no one-size-fits-all in terms of how you diagnose and stage. Almost every patient may present with some nuance. I've been asked to just talk about the role of EBUS in lung cancer. Wow, I'm sorry. Sorry about that, guys. These are all research-funded grants, and none of my disclosures include any paid presentations. Just want to talk a bit about the importance of staging and a few of these other things. So this is why I say that I think it's no one-size-fits-all. Some days you're calling the interventional radiologist, and some days you're calling the pulmonologist, and some days, quite frankly, you should call your thoracic surgeon directly. It really gets based on these sort of 4 presentations. One is this direct invasion of the mediastinum. You can see the pulmonary artery has wrapped around. This patient actually, if you can see all the cuts, has nothing but an endobronchial lesion. CT is negative, but a central adenocarcinoma that has N1 disease. This is the typical discrete N2 disease with a single 4R lymph node, and this is a patient who has a peripheral clinical stage 1 tumor. And so when I see a patient, I look at these 4 presentations and I say, well, where would I go next? Would I go with EBUS to these cases? And when you ask that question, the first thing that you should answer with is, well, what is the false negative rate of PET and CT? And so here's the false positive rate, very rare, almost no false negative rate. Here what's interesting is PET and CT don't behave very well in patients who have central lesions. And you ask yourself, well, why don't they behave well? Well, it turns out that with central tumors, you can have microscopic disease that's metastatic to the mediastinum. Same with the discrete large lymph node. You can get a false negative and a false positive rate with PET, and we all know that if you see patients with a hot PET and a single lymph node and a patient with a post-obstructive tumor, it might just be an inflammatory lymph node. And then the last patient sort of begs the question, there's a low false negative rate, begs the question, do you need a EBUS or any kind of staging at all? Can you take this patient to surgery? What I would tell you is this is actually the smallest studied group of all. We really don't know what to do here, and sometimes we sort of flip the coin and say, well, today we'll take them for EBUS to pre-stage them, or we'll send them straight off for surgery, and it depends. Actually, it's sort of starting to depend, for me, on the size of the tumor, the T level. Again, there are multiple ways to stage the mediastinum, and you have to think about your local expertise here. If you can do mediastinoscopy really well and you don't have EBUS capabilities, then do a mediastinoscopy. I kind of don't care what you do as long as you do something to stage the mediastinum. What you should, though, is that the different modes of staging get to different areas, and so EUS really, in addition to getting 2L and 4L, really does get 7 and 8, 8 and also 9, level 9 lymph nodes. It's the only technology that gets down this low. What I would say, though, for the proponents of EUS or EUS combined with EBUS is that's a really rare lymph node station to have to get at, and we very rarely see that involved in patients with lung cancer. And then mediastinoscopy, for what it's worth, really only gets anterior 7 and then the 2R, 2L, 4R, 4L. And blind bronch with TBNA only gets this area. EBUS kind of gets all of them except 8 and 9. And I wanted to point this out, that non-accessible by either EBUS and EUS is this level 5 and level 6 lymph nodes on the other side of the aorta, and the only procedure that gets to that is either a left anterior mediastinotomy, so-called Chamberlain procedure, or a VATS, and most kids now, most of the young thoracic surgeons will do VATS to get to that area. And again, mediastinoscopy gets in here. This is the area that Chamberlain procedure or a VATS can get to on the other side of the aorta, and this is mostly seen with left upper lobe lesions. So this is the crux of what we did in 2013 guidelines, and this is a meta-analytic look at the characteristics of all of the procedures. And this is the first time that EBUS sort of took hold as the first procedure of choice for staging the mediastinum. You can see that 2,700 procedures in 31 studies with a sensitivity of 89%. Interestingly, mediastinoscopy, which has almost 10,000 procedures, the sensitivity was 78%, and that was statistically significant. Really led us to change from the 07 guidelines where we said, look, all these procedures are good, and they're reasonable, and you could use any, but you know, we had a dogfight, and the surgeons, as always, tried to beat us down, and mediastinoscopy was listed first. And in the text, it sort of still suggested it might be the staging treatment of choice. But in 13, it said, look, in these patients, any of the needle techniques should be used as the first recommended test over surgical staging. So the standard of care now in places where you have competency and the equipment is to use EBUS as the first test of choice for staging the mediastinum. So let's just quickly go through and look at these. Look, anything can get to this. You can stage the mediastinum here with almost any test. Blind transbronchial needle aspirate would work here. One thing I would tell you is that we would try to, and this could be a small cell, by the way, we would try to stage this patient using EBUS. The reason is we want to get plenty of samples to send for molecular markers in this patient. They're stage 3B already, right, because they've already invaded directly into their mediastinum, so it's a T4 lesion. So no discrete visible nodes, intrathoracic stage is clear. The issue is simply to confirm the diagnosis, and you could actually use any one of these technologies, although you can't really get markers with sputum. I've seen some people do it, but I wouldn't recommend it. Now listen, if the patient is performance status 3, you don't need to do markers because you want to make a diagnosis and then get them supportive care or hospice. How about the patients back with the discrete mediastinal lymph node? In this, there's a high suspicion of N2-3 disease, definitely there, right? And with or without uptake on PET. So a needle technique would be the first test of choice here. And so for patients with peripheral clinical stage 1, what do you do? So by the way, the grade of recommendation on all the other ones was a grade 1B or 2A. Here, we really don't know what to do, and this is more of a consensus statement grade that for patients with peripheral stage 1A, negative nodal involvement by CT and PET, it's suggested that invasive pre-op evaluation is not required. And again, what I'll tell you is if we see larger tumors, and I don't know if anyone's seen the new staging classification for lung cancer just came out in Journal of Thoracic Oncology, and they're going to yet split up the T stage like a T1 through 5 almost, where 1 centimeter tumors are have a better outcome than 1 to 2 and then 2 to 3. In the last iteration, we split it less than 3, greater than 3. Now it's sort of almost a 1 through 7 centimeter thing. And so what we do know is that as these tumors get larger, there's more likely to be N1 involvement or N2 involvement. So small, less than 2 centimeter lesion, we're sending directly to surgery. And other than that, we're sending them for EBUS staging. What I will tell you is sometimes our surgeon will ask us to do it first just because the patient's sort of a high-risk patient and they're looking for any reason not to have to do a lung surgery, and so we'll certainly do it that. So in summary, in a 10-minute talk, imaging alone can't establish an appropriate stage and should not be relied on to make clinical decisions. Tissue confirmation is necessary. A lot of tools exist, and I think we too often get into this debate over whether it's surgery, whether it's EBUS, whether it's transthoracic needle aspiration. But honestly, it really is the availability and technology and local expertise. We believe for EBUS is the first test of choice based on its performance characteristics in staging patients with the mediastinum. And I'll thank you for your kind attention. I think we're going to wait until the cases to ask questions. Is that right? All right. Thank you.